Right, well, good morning everybody. I've been told this does work, and it does. Marvellous. Engaging health and social care professionals and new technologies. I saw that yesterday. I know it sounds like last minute and everything else, but I've been thinking about this for the last week or so, and I've been thinking about how we've been looking at new technologies, and we've been thinking about long-term conditions and how it all works within the Whole Systems Demonstrator program. And yesterday I thought, well, I'll just have another check and have a look at what I'm saying. And then I saw the title and I thought, actually I like that. Because I did think about whether, just to say to Nick, I'm not going to talk about that, I'm going to talk about something else. But I thought I like that title. And it got me thinking about technologies for what purpose. So I altered what I was going to do slightly and put this in yesterday, because it started making me think. This is how I've been rationalising things in my own mind for the last few months now. So why are we thinking technologies? Why are we thinking about the assistive living technologies, telehealth, telecare, telemedicines, call it what you like? Why are we thinking about it? And I rationalise it in very much this sort of fashion. The sort of latter 50 years of the last century was very much about eradicating those communicable diseases, finding new treatments, understanding better surgical techniques, developing approaches which have really almost got to the point where you would argue we've in this Western health systems on top of those type of things. But then it's there's still improvements to be made. There's still going to be new technologies coming through. There's going to be new techniques, but the growth area is going to be around those people with non-communicable diseases, so long-term conditions, chronic health diseases. And I think that's where the first half of this century is really going to focus. What are we going to do about all of that? How are we going to coalesce that? It got me again thinking about the creation of the NHS back in the 1948 and all of that. And it got me thinking about some of the apocryphal stories about Beveridge, when he went around looking at what we needed to be doing and how we needed to be thinking about healthcare, that there was this big pot of demand of people who, if we could just get some medical care to those people, then we would solve their problems within 2, 3, 4 years, and there'd be a lower demand on the health services, people's lives would be improved, and we would be able to run along at the levels of spending that we thought were necessary. And then by the early 50s it was obvious that that wasn't the case, and we needed to bring in prescription charges to start bringing in extra income, etc., and all the history of the NHS after that. And you can see how those messages started to develop over that period in the last century. And I think we're going to be in for a similar story over the next 50 years, and technology is going to play a hand in that. But let's not get hung up on the idea of these technologies are something scary or something to add on or something different. Because again, if you think back to that first part of what I was talking about, the last 50 years of the 20th century, we had technologies developing, we had new ideas coming into healthcare. When I just threw a couple in there because off the top of my head, but the MRI scanner, the CT scans, those are things which in 1950 were beyond people's realms of comprehension in everyday healthcare. So we had to introduce those. We started to see how those would work. Isn't it not the case to argue that it's the same thing when it comes to chronic healthcare, long-term conditions? And isn't it true to say that it is going to be a similar approach to thinking about how we engage people to use those technologies for the benefit of healthcare and the benefit of patients, rather than thinking about the benefit of the technology? And it's important to think this because, as I said, I believe, and I'm looking at this from a chronic health long-term conditions point of view, that's the area that I'm interested in from the Department of Health, we have a changing population. People are living longer, people are going to be developing conditions earlier in life as a result of lifestyle choices, as a result of the smoking, the lack of exercise, poor diet, whatever you want to use as the causes. The population is changing, and so we're going to have more and more people living with chronic health needs. And it's mirrored here in England. we have over 15 million people in England with a long-term condition. We use the numbers from the household survey, general household survey, and that just identifies those people in a household. So it doesn't always cover those people in, for example, university, or in prisons, or in care homes. So there's over 15 million. We know that, and we know it's going to that those numbers are going to increase. And over the next 5 or 10 years, we're going to see comorbidities increasing. The expectations, looking at the data, is that it's going to be the 3, 4, 5 conditions that are going to be more prevalent. We're going to see that growth. And we know that the costs are high. We know that over 70%, I think it's about 72% of all bed days in England are people living with long-term conditions, 65% of all outpatient appointments and over 50% of GP appointments. So these people are using the services. So you've got about a third of the population using the majority of the services and costing the service 70% of spend. Now, wouldn't it make sense to think about how we can use that spend, use that activity to improve outcome and improve the life and independence of people who are dependent on these services? And to my mind, that's where we can really start to see the benefit of the new technologies. It's not just about reducing hospital admissions, and some people say this is about, return on investments and savings. Those are very important. It is about people. It's about people wanting to be independent. It's about people wanting to live their lives at home, about not spending as much time in hospital. And I'm sure you, as I, have spoken to many people who will say, yes, I go into hospital, I spend time in a hospital bed, I use A&E services, but that's not really what I want to do. I want to be able to live my life in as normal a manner as possible for me. So they want their own goals, they want their own lives back. And that to me is about how we design services, about how we make sure that people living with these conditions are going to get the care that they want in a setting that they want to support them to do the things that they want and not have the condition dictate the life that they have to lead. But it's also about carers, the informal carers. We know there's for every one person with a chronic illness, there's often, someone around who's there to help care for them. Certainly once you get into the more complex conditions and people with more severe need, that is definitely the case. Often it's about a spouse or a child or a parent caring for someone else. And again, you like I, I'm sure, have spoken to people who've said, I'm happy to do this, but it has a big impact upon my life. It prevents me from doing things. It makes me worry all the time. So if we can do something which improves the life of carers as well, isn't that a good thing? Supporting community health staff and making better use of scarce resources, isn't that a good thing? If we could do some of that as well. So the point I'm trying to get to is that it isn't just about the technology. It's about thinking about the whole service, the whole system, and thinking about how we can deliver a care service which is focused around the needs of those people, the wants and goals and expectations of those people, and deliver something which will then help to support a life which they want and their carers can enjoy with them. There are examples. This is just one, but there's lots of examples of equipment which has already been deployed. There's lots of examples of people around the world using telehealth in a way which supports those with chronic health conditions to stay at home. Examples of where telecare is supporting people with health and social care, or just even social care needs, to have a more independent life. So there's lots of examples, and I just threw that one on there because I thought it's just an idea. But the issue has been about the UK evidence. Where's the evidence base that really could drive forward some of the changes to help people make those commissioning and provision decisions about the services and care that they want to deliver? And that was where we came into it with the Whole Systems Demonstrator program. And we can go back to about 2006 when it became obvious that there was not a robust evidence base which everybody subscribed to, which we could then say, there you go, that's how it works, this is why it works, and this is the the outcome you get if you implement it. But as I said before, that doesn't mean there wasn't some evidence somewhere, but this is about trying to develop that evidence base on a larger scale. So we in the Department of Health had a commitment. We will try and put together a trial which will deliver healthcare, but also show you how you can use technology, telehealth and telecare, at a sizable investment to be able to bring benefits to a larger group of people. We decided to do a randomized controlled trial, and that really gives us the academic credibility, but also the clinical credibility to be able to say it has been run. We have been able to identify the differences between normal care and intervention care, for example. And it's been we say a 2-year study, but actually it's been going for a long time in terms of development, getting the people engaged in terms of the sites, and then recruiting people onto the program. But effectively we got 3 sites. We've got 3 sites across the country, in Cornwall, Newham and in Kent. And that gave us a good spread of rural as well as urban, and a mixture. We got over 6,000 people, and in that number we managed to find nearly 500, I think it was, carers as well. So we're looking at carers. And we got 238 GP practices involved. So there's a lot of effort being put in by a lot of people to get to that position. It was very interesting early on that part of the early learning was that recruitment of people onto a randomized controlled trial is not easy, number one. We were told that at the beginning, we found that out the hard way. Number two, trying to get somebody into a way of thinking where they use technology to support and remotely monitor isn't as easy as just buying the kit, putting it in and seeing what happens. You've got to change your service. All those things that I said at the beginning. We have to think about why we're doing this and changing the service accordingly and introduce technology appropriately. And we've got evaluation of the Whole System Demonstrator program through some leading academic institutions, and there's a list there for you to see. And the King's Fund have been very instrumental in helping to coordinate some of that evaluation as well, through Chris Hann here at the King's Fund, and people like Nick Goodwin here, who's been helping with a number of other areas as well. We've got a lot of interest. I've had people come to see me from Finland, we've had Australia, we've had people from the European Union. I've even had the Taiwanese interested in what we're doing, because this is a worldwide issue. People are extraordinarily keen to understand the way that you implement telehealth, telecare, telemedicine, assistive living, and how it makes a difference, and whether or not you do get that return that you're looking for. So it's something that people are looking for and looking out for, and I keep getting asked, I used to say I get asked daily, but now I get asked about 5 times a day, when are the results going to be available? I'm not going to give you the results today. Where we are is we do have the data with the evaluation teams, and the evaluation teams are working through that data and are coming to conclusions, and I'm speaking to them and seeing some of that work ongoing, and it is extraordinarily complex and extraordinarily detailed, the work that they're doing. With it being a randomized controlled trial, we also are looking at peer review and then publication. So there's a lengthy process to go through. We were in a position where the recruitment took us longer to get people onto the program, so it took a bit longer to get the data in, so it's obviously taken a bit longer to get the data to the evaluation team, and it's going to take a little bit longer to get the data out. It's imminent is all I can say at the moment. I've been speaking to the evaluation team on a regular basis, and it is imminent. The evaluation themes, what we're actually looking for in the program, we broke this down into 5 themes. Put them up on there with some of the numbers to give you an idea of how we've broken this down. But effectively we wanted to understand what's the clinical impact, what are the issues around carers, what are the issues around organisational development, is there a return on investment, do you get the change to the service that you're looking for. So those sort of things are what we're trying to find out. The biggies for a lot of people is the return on investment. If I invest X and I develop services using this this approach, do I get Y, or do I get Y but I'm still spending X elsewhere? So effectively, am I going to make a saving? Is it going to be additive, or is it going to be improved outcomes for everybody but at a cost or a low cost? So there's lots of questions that we need to understand there. But the fundamental for me, the fundamental issue for me is, does it improve outcomes for people? Does it overcome that issue of the 8,760 hours in a year, about 6 hours are spent with somebody with long-term conditions in the presence of a health or social care professional. The rest of the time they're on their own making those decisions daily for themselves. So does it overcome that period of time, that large majority of the period of time when people are making decisions for themselves, and does it give them an opportunity to have a proper interaction, if you like, with someone whilst they're not actually there? And to me, the technology is a means of transmitting data, quality data, quickly on a regular basis, allowing people to have that confidence in the approach that's being taken and the support that they're receiving. If we can get to that, then will the savings come from that? And I think, you know, part of the answer to that is, will we be able to get to the point where the cost element of the intervention is equal to or less than the cost of doing it elsewhere? And that's, to me, where WSD will help us move down that path, because we're trying to understand that message as well. Experiences to date, I've touched on some of them. The technology, though, is only one element of success. I think we've put up there 10% of the effort. And I think the people in the audience today who are from the 3 sites would probably agree with that. The technology itself, identifying, you know, your supplier, identifying the equipment that you want to use, installing it, training people in how to use it, and then being able to interpret the data. It's about 10% of the effort. The rest of the time, and the rest of the effort, is actually in designing the services appropriately and engaging people in that long-term conditions model, the chronic care model, about risk stratification, about supporting self-care, about one-to-one case management for appropriate levels, about care planning, personalising the messaging, etc. What I think has been very clear to me, and it's the last bullet point I put on there, is what you might have been doing elsewhere already on a small scale doesn't always mean you can just translate it into a larger scale. Each of the sites were looking at 2,000 people, roughly. And each of the sites had started thinking about how to deliver and how to develop. But I think what was obvious is, if you'd been doing something previously, it doesn't always translate that you just scale it up. You've got to think, why are we using this technology? Why are we trying to do something different? And then develop and build from there. And I have seen around the country a number of places where people have gone to the supplier, you know, various suppliers, settled on a particular type of equipment, purchased 10, 20, 100, whatever it is, taken them away and thought, right, now what are we going to do? And it's been very, very hard to then roll it out in a meaningful way. You have to start by thinking, what are we trying to change? Why are we wanting to introduce the technology? And then do the change with the technology. So the key to success, I think, is look at service change and then think about how you use the equipment and how you would implement it. But what else is going on? What else do we need to think about if we're going to engage professionals in using this technology? Well, I think we need to think about beyond Whole System Demonstrator program. And we need to think large scale. We need to think how many people could benefit from this approach. We know there's 15+ million people with long-term conditions. We know that if we change the services and the approach to people with long-term conditions with a more of a generic model where you, as I say, focus on risk, identifying the right people, stratify them, put in the appropriate support, particularly around the self-care elements as well, things will begin to change. So to do that, I think you need significant leadership at all levels. We need to raise awareness of what can be achieved and how the technology can be used properly. And that, to me, means we need a direction. So if you're looking at doing this locally, you need to think, well, what is my direction here? What am I trying to achieve? Why am I trying to improve care for people with long-term conditions, chronic illnesses? Why am I wanting to use the technologies? But I think beyond that, we need to think about the incentives. We need to about how do we align those incentives. Why, as a commissioner, would you want to invest if, once you've invested, any saving is elsewhere, somebody else has got that saving? Why, as a provider of healthcare, would you want to engage in a different type of approach if you're going to get the money in anywhere, without any change, without any effort? So we need to understand how you can align some of those incentives to make it more attractive to people to get engaged. And I think there's issues about retraining staff to think differently about the way that they deliver care, about engaging with this chronic care model and using the technology. So there's obviously issues about, when you're going to deliver this, have you got the right staff, have you got the right approaches? And I think the interoperability is extraordinarily important. If you want to use a pendant alarm and it doesn't, for somebody who might fall and have an alarm, press that to be able to raise awareness, and it doesn't work with the home hubs that you've got elsewhere in your locality, you're stuck. You've got to be in one place or one manufacturer's kit all the time, and you might actually want to mix and match. So it's about this interoperability, and it's a challenge which I think has been thrown out to industry, and part of I think what Graham might talk about with Dallas is about how do we overcome some of those issues. Common standards, I think, is extraordinarily important, so that everybody across the piece knows that if I go to develop this, then I get that type of a standard. And I think the high unit cost, 2-3 years ago when we started out down this route, it was obvious that it's small scale, small numbers. Small scale, small numbers equals high cost. And it's an economy of scale and a volume issue. And once you got into high cost, it becomes more and more difficult to be able to afford it in the first place, and secondly to realise any return on investment. So another challenge to the industry is how do we bring that cost down? And of course their challenge back to us is give us the numbers and we might be able to bring that down. But I think there's different models about how you can deliver. Rather than buy, you might go for lease rather than go for lease, or you might go for risk reward. I will introduce it as long as we share the reward, and I'll give it to you for free. There's all sorts of models that are now developing, so it's about reducing that cost. And in the growth review that came out as part of the budget back in the spring, government did commit to do to address some of those issues. There was a support for an industry-led code of practice, and what we've been trying to get off the ground in the TSA, the Telecare Services Association, have actually taken up the cudgel on this. As we're wanting some sort of code of practice, so that if you want common standards, you know that you're going to have a code of practice that people work to. You know that if you invest with this company, there is a certain level of practice that you're going to expect, the same as if you invest in that company, etc., etc. So there's work ongoing on that. And also in the growth review, there was a commitment to invest in Dallas. I think the total figure was 24 million, was it?
23.
23 million. Thank you. Mike's holding up 3 fingers, I can see from this distance. So 23 million across the whole of the UK. So there's commitment here to do something differently. But I think there's still more that can be done, and as I've said there, I think there's a lot of patient pull still. And I think as we start to see it implemented and develop, and people using it, then it will become, well, I like this. This is something I would like to do more of. And relatives and friends, and as the messages grow, you'll start to get to the point where people are coming into the services asking for it. So again, I think it's about how we can use some of the medium out there, the local media, some of the national media maybe, to get some of those messages across about what it is, how it works, and how people can access it. So I think there is still more that can be done. But the message really is about giving people the support where they want it, when they need it. And these two gentlemen are actually part of the WSD trial. And that's just some of the equipment that they've been using. And I don't obviously want to preempt any of the results. We need to make sure that we have the academic integrity kept intact. But the fundamental issue coming from every single person that I've spoken to about the WSD is They think it's easy to use, they think it makes a big difference to their life, and they really think other people should be using it. And I just think it's incumbent upon all of us to start thinking about how we can deliver this in a way which really does engage people, because if we don't, we might be losing an opportunity. I just wanted to finish with this. I like this. I saw this many years ago. It's something Nelson Mandela said, and it's vision without action is merely dreaming. Action without vision is merely passing the time of day. But if you combine vision and action, you can change the world. To my mind, that sums up how we engage and use technology. If we're not careful, we're just going to be dreaming about this. Let's stop dreaming. Let's stop thinking we need more and more small-scale pilots. We've got WSD, we will have the evidence, we will have an evidence base which will give people information to help them make decisions locally. But let's not just go out there and buy all this wonderful equipment because it's there. Let's combine the two. What we're trying to do, why we're trying to do it, the vision that we have, with the appropriate commissioning of services and use of technology, and we will make a difference, and we will make a difference, I believe, to a number of people's lives. So that's all I wanted to say, but thank you very much, and hope that was helpful.